Honestly speaking, Doctora, I'm not an authority on this matter. Now, as I was doing the slides, I came across Albert Einstein's quotation, and I would like to share with all of you. And it reads, and I quote, "Imagination is more important than knowledge." And to continue, at the end of my lecture, we are expected to have recalled the meaning of DIE. We should be able to contrast ultrasound with MRI. As regards diagnosis of deep infiltrating endometriosis. Number three, let us talk lengthily about IDEA, otherwise known as the International Deep Endometriosis Analysis. Now, number four, recent years have witnessed a sea of change on the innovative techniques to further the diagnosis of DIE. Let me update you on these things. No, we have the saline sonovaginography, the gel infusion sonovaginography, rectal water contrast, transrectal endoscopic sonography, and sonopodography. Excuse me. Before we end this lecture, Dr. Kriya Del Castillo will show us videos on how to perform the steps of DIE, and she will report on an interesting case that she and I have actually scanned pretty recently in our section. So I'd like to start by asking, why does endometriosis matter? It's a very common yet under-recognized condition. In fact, it is even more common than breast cancer, prostate cancer, and diabetes mellitus. It significantly impacts social and work participation. Have we ever imagined the multitudinous medical certificates of leaves of absence that you have issued on a monthly basis because of recurrent dysmenorrhea in a background of normal ultrasound? So with that, at this point, I'd like to call on Dr. Kriya for the prevalence, incidence of DIE in the Philippines, worldwide, and during her fourth month of fellowship training in our section. The floor is yours, Dr. Kriya.
So for the prevalence doctors, a study done by Parazet et al. In Boston, which reviewed the epidemiology of endometriosis, pegs the prevalence at 10 to 15% of all women of reproductive age, with 70% of women with chronic pelvic pain. While another study done in Brazil showed a prevalence of 5 to 10% of reproductive age women. Locally, the prevalence of endometriosis is also estimated at 5 to 20%, with 30% to 40% of women experiencing infertility. And in our own institution, 15% of cases seen from Jan to March were due to endometriosis, with 89% presenting with endometriomas. Comparing imaging modalities for endometriosis, most studies state that endometriosis has always been hard to assess due to its ability to mimic other diseases and its complex atypical pattern. Transvaginal ultrasound is a reproducible, highly accurate, dynamic method for evaluating pelvic endometriosis, especially when a meticulous, dedicated protocol is followed with compartmental delineation. MRI, while with excellent tissue characteristic and multiplanar imaging, is limited by its cost, as well as patient's anatomical factors which may distort the image. Its use, however, as a complementary imaging in pelvic endometriosis is undisputable.
Thank you for that, Dr. Del Castillo. Suffice it to say that ultrasound is faster, cheaper, readily available, and acceptable by most patients. Now, I'd also like to mention as well that endometriosis is a heterogeneous multiform disease for which in 2001 the genetic epigenetic theory was sought after in cases of the presence of endometriosis in the absence of endometrium. Uh, we know that there is a high possibility of genetic predisposition in this disease. Now, may I remind you that there are three types of lesions. Number one is the superficial peritoneal disease. Number two is ovarian disease. And number three is deep infiltrating endometriosis. So, what then is DIE? No? DIE is defined as any endometriosis lesion infiltrating the peritoneum by 5 millimeters or more. Now, in 2006, Chapron et al. Published in the Human Reproductive Journal that surgical excision of DIE is risky. We know that, requiring long operating times. We also know that, and excellent technical skills. Therefore, and I think this is where sonologists come into play, the preoperative ultrasound mapping of all. It did not say some, it did not say few, but all endometriotic lesions is necessary prior to surgery. Okay. The next big question is, why is there a delay of about 7 to 12 years in the diagnosis of endometriosis? Two things. Number one is because of the deceptive symptoms of endometriosis, which could present as dyspareunia, dyschezia, and even subfertility. Number two actually concerns us sonologists, because of some queries on the suboptimal primary assessment of patients with suspected endometriosis. Now, I repeat the question, why is there a delay? Number one is that we know what we know of previously as endometriosis was equated only on the presence of endometrioma. Now we know that as we look at the iceberg picture to your right, endometrioma is only the tip of the iceberg, and that the drama of DIE lurks underneath. Please be reminded also that only 1% of endometriomas are truly isolated. And when you see kissing ovaries on ultrasound, that is highly suggestive of severe pelvic adhesions, which significantly increases bowel lesions to 18.5% and tubal endometriosis to 93%. All right. The other big question is, why is ultrasound assessment of endometriosis important? Dalawang bagay ulit. Number one is to help our patients understand their symptoms. Number two is to help our fellow doctors in triaging patients. We know that ultrasound mapping is used to accurately know the extent and location of the disease. Well, let me give you a concrete example. One Monday morning, as you went to work, you got a request from a general practitioner or primary care physician for a transvaginal sonogram on a patient suspected of having endometriosis. So you did the scan at 7 in the morning and you signed it out as adenomyosis. You did not see endometrioma, therefore you said that there was no DIE. Now, the referring general practitioner or primary care physician may be justified to just give medical management for the pain. Or I think the more sensible thing to do is to refer to a gynecologist for possible Mirena insertion, as the case may be. Now, the ultrasound assessment of endometriosis is equally important for fertility experts. Bakit? This is in planning appropriate patient care, especially in oocyte retrieval. Now, for generalists like me, general gynecologists, an ultrasound evaluation with DIE may actually require referral to a tertiary laparoscopic center, because I'm pretty sure you would not want to be caught unabashed to finding dense pelvic adhesions during your surgery and asking for help from our friendly surgeons and gynecologic oncologists performing the rest of the ultrasound for us. Now, for advanced laparoscopic surgeons, ultrasound assessment of endometriosis should be done to counsel them of the risks and possible complications. Therefore, when there is DIE on our ultrasound, it should be approached in a multidisciplinary manner. If there's bowel endometriosis, a colorectal surgeon should be consulted. And in cases of ureteral involvement, a urologist may likewise be seen. Now, for a long time, there was this lack of standardized definition in the ultrasonographic classification and diagnosis of DIE, and this became a general cause of concern. So in 2017, Professor George Kundus, during the ECOG at Melbourne, said that this lack of uniformity when classifying anatomical location and extent of disease contributes to the considerable variation in the reported accuracy of transvaginal sonogram in the diagnosis of endometriosis. Therefore, in 2016, the White Journal came up with this idea, otherwise known as the International Deep Endometriosis Analysis Systematic Approach to Ultrasound Evaluation. Now, actually, this was championed by 13 countries and 29 luminaries. The IDEA consensus aims to ensure that the ultrasound examination of a woman with potentially underlying endometriosis is performed in a standardized manner. Now, what do we mean by standardized manner? No? First, we mean that measuring the lesion, the endometriotic lesion in three orthogonal planes, length into width into height, pretty similar to how we measure a fibroid. Or the other option is to report the lesion using the largest diameter. Now, in the IDEA consensus, terminologies were used in describing localization of DIE, and this has become uniform and useful in clinical practice, especially in preoperative cases and future research. So now we go on to the discussion of the IDEA. There are actually four basic steps. Now, these steps are not necessarily done in this order, but I repeat, thoroughness every time is the key. Thoroughness in doing ultrasound every time is the key. We know that ultrasound is a dynamic modality wherein the probed hand sees what's inside while the free hand ballots the uterus and helps in performing site specific tenderness. So the first step is the routine evaluation of the uterus and the adnexa. In here, we take a look at the ultrasonographic signs of adenomyosis with the presence or absence of endometrioma. Now, the second step is the evaluation of transvaginal sonographic soft markers. In the White Journal, it was mentioned that we have two soft markers. These are site-specific tenderness and ovarian mobility. Now, step three is the assessment of the status of the pouch of Douglas, or you may call it posterior cul-de-sac, using real-time ultrasound-based sliding sign. And the fourth step actually is the most laborious for sonologists because this is the assessment of the compartments of the pelvic cavity into the anterior and posterior. Now let's take a look at each step. This is step one. Definitely we all do this. We check on the uterine morphology as to MUSA. Well, it is no longer the scope rather of my lecture. So in here, we check for asymmetrical thickening of the myometrial walls, like so. What is relevant is when there is a difference of about 5.5 centimeters and more. We take a look at poor endometrial myometrial junction by way of 3D gyne rendering. We take a look at fan-shaped shadowing of the myometrium. Then we click on the power Doppler for translesional vascularity. Please take note also as you scan the comma-shaped or the inverted appearance, comma-shaped or the inverted question mark appearance of the endometrium, which is highly suspicious of adenomyosis. Then we go to step two. What is step two? I mentioned earlier, we check on the soft markers. We only have two soft markers. Number one is the ovarian mobility by doing sliding technique. Number two is site-specific tenderness. Now, because site-specific tenderness is subject to the pressure of our hands, in 2020, the White Journal published hard markers as well. And these are the presence of endometrioma and hydrosalpinx. So what is step three? I mentioned that this is the assessment of the status of the pouch of Douglas using real-time ultrasound-based sliding sign. How do we do this? Simple. Ballot the uterus, perform sliding evaluation in the anteverted or retroverted or even mid-axial uterus. Now in here, we perform the sliding sign. We, have, we call it a positive sliding sign if there are no pelvic adhesions. And we say it's negative sliding sign if there are pelvic adhesions, which we should categorically include in the report. Now, don't worry because Dr. Cria Del Castillo later will show us videos on how to do the sliding sign. All right. So when you see a positive sliding sign in the pouch of Douglas, you have to mention in the report, is this retrocervical? Number two, is it at the level of the mid-uterus? Or number three, is it until the posterior fundal area? Or if the entire pouch of Douglas is obliterated by dense adhesions? Now, this is step four. I mentioned earlier that this is the most taxing to all of us, no? In here, we compartmentalize the pelvic cavity into anterior and posterior. The anterior compartment comprise the urinary bladder, uterovesical junction, the ureters. In here, we may not do transabdominal ultrasound to check on the kidneys. The posterior compartment of the pelvic cavity comprise of the posterior vaginal fornix, rectovaginal septum, and the uterosacral ligaments, I should say. Now, the bowels in DIE is always a special mention. So this is just a recap. I mentioned that in the uterus, we should use the Musa statement in assessing. Yeah, sorry about that. And then for the adnexa, we check on the presence of endometriomas or other ovarian masses using appropriate IOTA statement. We check on the mobility of the ovaries, including kissing ovary sign. And we check for site-specific tenderness on all the structures in the pelvic cavity. All right. So this slide is very important because it shows us the common occurrence of ultrasound endometriosis in this order. The commonest is finding endometrioma. Number two is an obliterated pouch of Douglas. Number three, bowel adhesions. Number four, USL or uterosacral ligament nodules. Number five, vaginal nodules. And number six, rectovaginal septum. All right. So this is a very helpful self-explanatory diagrammatic representation of DIE in step four. I mentioned earlier, and I will keep on mentioning, that the anterior compartment comprise of the urinary bladder, the ureter, and the uterovesical junction. We know that the urinary bladder has four zones and that the diagnosis of bladder endometriosis is very high. It's at 95% and it could be seen on any part. The first picture here under the anterior compartment shows us the trigone, which is zone 1. You see a measurable endometriotic nodule here. Kriya, bigyan mo naman ako ng ano. Over there, no? So the trigone is a smooth triangular area lying within 3 centimeters from the urethral opening and delimited laterally by the two ureteral orifices. Now, the second picture is zone 2, which shows us the dome, and the dome lies superior to the base. This is actually the commonest area for which a nodule is seen. Now, zones 3 and 4 are not included in the pictures, but it's worth mentioning that zone 3 is the bladder base. This one is adjacent to the vaginal wall, and that zone 4 is extra-abdominal bladder. Now, the sole criterion for endometriotic nodule in the urinary bladder is that the muscularis should be affected. Now, in scanning the urinary bladder, there should be minimal amount of urine. Let's take a look at the third picture here. The third picture is a picture of the ureter. The ureteral involvement in DIE is between 25 and 30%, and the area of involvement in this picture is the pelvic portion at the level of the crossing of the uterine artery, this one. So this is actually the commonest area to see a nodule. How to identify the ureter? The ureter is always identified in a sagittal position, and you move the probe laterally. Again, Dr. Cria del Castillo will show us later the identification of ureter in a video format. All right, next. This slide shows us this slide shows us a left hydroureter. So if you see hydroureter, please measure the distance between the dilatation and the distal orifice of the urethra. All right. So now let's go on with the posterior compartment. I mentioned earlier that the posterior compartment comprised of the rectovaginal septum, the posterior vaginal fornix, and the uterosacral ligament. we'll mention the rectum and the rest of the bowels later, no? Now, this part here shows us a lesion in the rectovaginal septum. What exactly is the rectovaginal septum? All right. So this area here with the green double arrow-headed arrow corresponds to the space below the line passing along the lower border of the posterior lip of the cervix. This is the rectovaginal septum. Okay, yeah. All right. The occurrence of nodule here is anywhere between 6 and 25%. What is the vaginal fornix? The vaginal fornix is this one. This is the space, the small space between the dotted red line and the dotted blue line. The occurrence of nodules in this area is about 65%. So seeing a nodule in the vaginal fornix is more common than seeing it direct to vaginal septum. The vaginal septum, the vaginal fornix, I should say, is retrocervical and corresponds to the attachment of the vaginal mucosa to the posterior lip of the cervix. All right. So in here, we see the rectovaginal septum. All right. We have here a nodule in the septum itself, but this is very rare. What is even more common is a nodule originating from the vagina that extends to the septum, or a lesion, an endometriotic nodule in the rectum encompassing the septum. Or it can be a lesion, a very large lesion, seen within the vagina, the rectus sigmoid, the vagina, the rectum, and the rectovaginal septum. So in here, we see a lesion at the posterior vaginal fornix. Now, of special interest here is the so-called diabolo-like nodule, or the hourglass sign. Now, this nodule actually crosses borders, and this is not seen, this is not visible at laparoscopy, which makes the identification of this diabolo-like nodule even more important on ultrasound. Now, this occurs when the posterior fornix region extends to the anterior wall, like so. The lesion is the same size as the one in the posterior fornix. This lesion is usually 3 centimeters and more, and if you observe, there is actually a small but well observed continuum between the two parts. Now, let's discuss the uterosacral ligament. What is the uterosacral ligament? This is a fibrous fascial band on each side of the uterus that passes along the lateral wall of the pelvis from the uterine cervix to the sacrum, and that serves to support the uterus and hold it in place. This is also called the sacro-uterine ligament. Ito yung pag nagtatabiso tayo, yung nasa likod uh, ng uterus that we have to ligate. In some patients, this is very prominent during tabi. So in some patients, you could hardly see the uterosacral ligament. Now, in looking at the uterosacral ligament, or USL, you have to magnify the image to include the upper vagina and the lower uterus to be assessed in the sagittal plane from uterine artery to uterine artery. In the transverse plane, this should be seen from the external to the internal cervical os. Now, the involvement here is between 15 and 30%, and SST, or site-specific tenderness, should always be applied on all structures in the pelvic cavity. Then please click the power Doppler on all lesions, and you have to report also the vascularity, pretty similar to how you report the vascularity and the endometrium, that is color score 1, 2, 3, and 4. So this is what I mentioned earlier, how to check on the uterosacral ligament. Now, on this part, you see a nodule in the right uterosacral ligament. So if the nodule is seen as a central block of hypoechoic tissue like so, at the retrocervical area, we call this an arciform abnormality. This is actually an endometriotic nodule or a lesion in the torus uterinus. So kung sa gilid, uterosacral ligament, sa gitna naman noon, we call it torus uterinus. Now let's go on with the bowel endometriosis. Now the bowels are dichotomized to the anterior rectum, which is affected in 64% of cases, and the rectus sigmoid and sigmoid colon at 21% each. There is also an entity here, which is deep intestinal endometriosis. Now, let me remind you that the criterion in bowel DIE is that the nodule must infiltrate at the muscularis propria. If the level is up to the serosa only, this is not called DIE. Then it's probably some other form of colonic pathology. So, yeah, balik tayo doon. Sorry. Okay. So in this diagrammatic representation, the red line here represents the lower or the anterior rectum, which cannot be seen on laparoscopy. Then after that, the pink line is the upper anterior rectum, which is visible at laparoscopy. The green line is the rectosigmoid colon. And the fossa over here, number 4, is the anterior sigmoid, which extends up to 18 centimeters. So this is how to measure the distance of the endometriotic lesion on the rectal wall. No, the probed hand inserts the transvaginal probe into the rectum, and then yeah, all right. You have to measure the anal verge. Then you remove the rectum and get a tape measuring device so that you will be able to measure the length of the anterior length and the of the probe length anterior verge distance. Okay. So this is the diabolo-like sign. It's called diabolo because it reminds us of the horn of the bull. Next slide, please. All right. So I mentioned this earlier. Next slide. All right. So let me just remind you of the layers of the normal bowel. We have the serosa, which is the thin hyperechoic line, the muscularis propria, both longitudinal and circular, two hypoechoic strips separated by a fine hyperechoic line. Then we have the submucous and the muscularis mucosa. Okay. Priya, please. All right. So this slide shows us the morphological types of bowel DIE. No? Let's take a look at number 1. This is a nodule with a relatively regular outline with the absence of spikes. Number 2 is a nodule with a progressing narrowing as a tail. This is also called the comet sign. Number 3 is a nodule with prominent spikes towards the bowel lumen. Number 4 is a nodule with prominent spikes towards the bowel lumen and a progressive narrowing as a tail. Number 5 is a nodule and extrinsic retractions as pulling one sleeve. Number 6 is a nodule with prominent spikes towards the bowel lumen and extrinsic retraction and visible mucosal folds. Next slide, please. Let's take a look at how these morphological types of bowel are seen on ultrasound. So this is a nodule with a relatively regular outline. This is how the comet sign looks like. There is a progressively narrowing tail. Now nodules C, D, and E are so-called moose antler sign, otherwise known as the Indian headdress sign. Next slide, please. All right. So why is it called moose antler? Because it looks like the antler of the moose. And why is it called the Indian headdress sign? Because it looks like the Indian headdress sign. When you see this is deep endometriosis with bowel involvement, the presence of hypoechoic mass with rectosigmoid involvement, characterized by thin band echoes departing from the center of the mass. All right. So we're done with step 4, and now I would like to update all of you of the new innovative techniques that will aid in the diagnosis of DIE. These are, as I've mentioned, SSV or saline sonovaginography, gel infusion sonovaginography, rectal water contrast, transrectal endoscopic sonography, and sonopodography. Let's try to discuss this very briefly one by one. So the SSV in here, the sonologist needs an assistant who injects, excuse me, about 200 to 400 ml of sterile saline through a Foley catheter inserted only into the vagina. Now, this saline acts as an acoustic window that actually distends the vaginal walls, the fornix, USL, POD, RVS, and the vulvovaginal septum. It is very reliable and very simple method for assessing rectovaginal endometriosis with a sensitivity of 90.6% and a specificity of 85%. Now, transvaginal ultrasound alone gives us a sensitivity of 43.7 and specificity of 50%. Okay, this is a picture of how the saline sonovaginography is. So this part here is the Foley catheter that's inserted only at the level of the vagina. This is the probe, and this is the fluid, the sterile saline that has been installed. So you see here the rectovaginal septum, rectovaginal fornix, the posterior vaginal fornix, and the anterior wall of the posterior wall of the bladder, I should say, being outlined with the fluid. Now, the other one is gel sonovaginography. In here, instead of using saline, we just put gel within the posterior vaginal fornix. The only problem here is you have to be very quick at measuring the endometriotic nodule, because the moment air becomes visible, it can be seen as an artifact already. So what Professor Kundus did here was to do gel sonovaginography together with 3D render imaging, so he can get back to all the pictures that he saved. No? So gel sonovaginography is very good at the prediction of bowel DIE. And although the sensitivity for RVS DIE was limited, gel sonovaginography had a high specificity and negative predictive value for all forms of posterior DIE. Next, let's talk about rectal water contrast transvaginal ultrasound. Professor Kundus was the first one to include this in the journal of ultrasound in medicine. In here, the ultrasound probe is in the vagina while tepid water has been infused into the rectum. This is still under investigation. The same thing with the the other one, no? The transrectal sonovaginography. Now, this one is the newest method termed saline infusion sonopodography. This was reported in 2019, again by Professor Leonardi and Professor Kundus. So sonopodography predicts superficial endometriosis with a sensitivity of 65% and a specificity of 100%. You perform this by installing or instilling saline into the pouch of Douglas via an intrauterine balloon catheter. So this is pretty similar to how we perform SISH, only you have to wait for the fluid to be seen in the posterior cul-de-sac or the pouch of Douglas. So this is how it's done. There is fluid here, and you can see a very tiny nodule at the uterosacral ligament, at the area of the uterosacral ligament. And then you see here the break at the area again of the uterosacral ligament. These are some small adhesions which are accentuated by sonopodography. This is another form of a flimsy adhesion. And there's a very tiny endometriotic nodule over this area. So this is likewise to mention that there's such a thing as UBES, no? I'm sure we all know this, and this is the ultrasound-based endometriosis staging system, wherein the ultrasound results of DIE is being evaluated relative to the gold standard, that is laparoscopy. And then there's another one here, the Revised American Society for Reproductive Medicine classification of endometriosis, which was revised by Enzian, the Enzian classification. Now, in here, the nomenclature is actually analogous with the TNM classification of malignant tumors, but this is still under investigation as of this time. So, should you want to know more about the performance of transvaginal ultrasound and DIE and the uterosacral ligament assessment, you can scan this with your QR code. And this is the book that I used for this lecture, How to Perform Ultrasonography in Endometriosis. Now, with this lecture review, I have learned that I still have a lot to learn. This is just a quotation from Maya Angelou. So that ends my lecture. Are there questions?
Thank you, Dr. Bustos, for that very comprehensive lecture. Are there any questions from the
I hope
audience?
not. Are there any comments instead, insights? If there's none, then
Wait lang. Hindi ako makapapasok eh. Ayun. Okay. Um, yung huling ginagawa, yung vaginophotograhy,
sonovaginography po, Doktora.
sonovaginography.
Or yung
The
sono...
last one you said,
Yes,
where
Doktora.
you have that fluid in the posterior cul-de-sac.
Yes po.
What do you call that technique?
The saline infusion sonopodography po.
Sonophotography. So is this
Podography.
the same as
Kasi po
doing
yung...
a CISH and
Yes,
then
Doktora.
just waiting for the fluid to settle in the posterior cul-de-sac?
Yes, Doktora. Exactly po. That's why they called it,
Exactly.
yes, Doktora, POD kasi pouch of Douglas, sonopodography.
Okay. So it's as simple as doing your ultrasound after your CISH, isn't it?
Opo. Yes po, Doktora.
Okay. I must congratulate Doris. You're so good already, Doris.
Doktora, hindi po. Salamat po.
Pwede ka nang maging lecturer. Okay, I'm so
Ay,
happy.
akala ko para mag-DIE, mag-lecturer. Doktora,
Uh,
we still have the video from Dr. Cria del Castillo. This is just a 10-minute video. She will explain, and I'm so proud of our fellow because at this point, she knows all these things already. The virtual floor is yours, Doktora.
Wala na ba ibang questions or comments from the rest of the attendees?
Doctor,
Question po.
Dr. Bustos,
Yes, ma'am.
I was wondering with regards to the saline infusion into the vagina.
Yes, ma'am.
How do they do that since they are going to infuse you were telling us 200 to 300 cc? Di ba lalabas yun? Parang super dorsal dichotomy ba yung patient? And then you have the probe and also the catheter in the vagina.
Doctora, the technique here is to inflate the balloon of the catheter big enough to cover the vaginal canal so that the fluid will not be coming out. And you really have to be very quick at doing this. So,
Ano yan? Unang nilalagay ba yung probe? Yung vaginal probe bago i-infusan at saka lalagyan ng ano?
hindi
Baka,
daw po.
hindi. Ipapasok din yung yung probe.
Opo, Doktora.
Ibig
Kasi
sabihin, mabilisan yung pag-assess mo. Parang ang
Yes,
hirap
ma'am.
ata.
Yes,
Pang
ma'am.
expert.
Oo nga eh. Mas madali po yung
Kasi-
gel sonovaginography. Kasi hindi mo na
Mas
kailangan
nagstay.
it stays. But the problem is, if there's air already within the gel, ganito na itsura niya. Puro siya artifacts. So
Oh.
again, you have to be very quick at looking at the endometriotic nodules over this area. So kaya po ang ginawa ni Professor Kondus, he incorporated 3D gyne with the 3D gel infusion so that he can keep on coming back and looking at the structures.
So with that 3D gyne, he can just review.
Yes, ma'am.
Um, okay.
Pero
Thank you
mahirap
po.
pa rin.
Yung nga
Welcome po.
mahirap.
So, kailangan pag-aralan, practice makes perfect eh.
Opo, Doktora.
Dr. Susan, you have a question?
No more na. Thank you.
Thank you, Susan.
Congratulations, Dr. Doris.
Sus.
Excellent lecture.
Salamat po. Here is Dr. Cria del Castillo. Buong buo yun.
Thank you, Dr. Doris, for that comprehensive lecture. And now to apply what you have just taught us, we will show you some ultrasounds and the corresponding laparoscopic findings. So to start with the ovaries, so first we have a laparoscopic depiction of a large left ovarian endometrioma that has just ruptured with the point of rupture here. It is slightly stuck to the pelvic side wall. Here we have a video depiction of a much more adherent left ovary without any endometrioma. The left fallopian tube is also stuck here to the pelvic side wall. With laparoscopic tools, they are using a very strong force to be able to bluntly dissect the ovary off of the side wall. This ovary is also stuck at the level of the uterosacral ligament, which is just under here. And the ovary is also stuck to the uterus, you can see. You can see all of this disease around the ovary, and they are working very hard to push that ovary up and off to normalize the anatomy. In this video, again, we have a very, very densely adherent left ovary, which is just underneath the instruments here. Here is the fallopian tube. And the goal is to mobilize the ovary, which also has an endometrioma. And you'll see a rupture of the fluid right here. So this ovary is very close in proximity to the ureter here. And in order to safely excise the endometriosis and the endometrioma, there's a need to move this away from the ureter here. Now here are some sonographic depictions of the ovaries. Here's the ovary. And with a transvaginal probe rolling in and out to push that ovary, we identify its mobility against its surroundings. So a positive sliding sign. Here we have an ovary that is also mobile. Particularly, we are trying to assess the mobility against the uterus in this plane here. And you can see that there's also sliding present. Here we have an ovary that is also mobile, particularly, but in some areas they adherent. So against the pelvic side wall, we can see some mobility, some sliding, but it is very clearly stuck to the uterus and to part of the pelvis here. And this ovary has an endometrioma as well. In this video here, we have an entirely fixed left ovary with an endometrioma present, and it is fixed against the uterus here and the uterosacral ligament, as well as the pelvic side wall. So we have a negative sliding sign. In this video, this is the ovary, this is the uterus and the uterosacral ligament. And within the ovary is a small endometrioma. And you can see this area of irregularity here, and this ovary is completely stuck to this spot. In order to safely dissect the ovary and remove the endometrioma, you need to be aware of this preoperatively. And this is very close in proximity to the patient's ureter. Here we have a video of bilateral ovarian endometriomas, left and right, and they are adherent to each other in the midline, the so-called kissing ovaries. You can also see a hypoechoic nodularity in the midline, which is rectal deep endometriosis. So anytime that you see an ovarian endometrioma, we should have a high index of suspicion that there is coinciding deep endometriosis present. To assess the rectouterine pouch, also known as the pouch of Douglas or the cul-de-sac, this is very important to be able to describe sonographically to allow for good surgical planning. So this is a normal pelvis and a normal pouch of Douglas. You can see the uterosacral ligaments here joining at the torus uterinus. There is peritoneum overlying the pouch that is very normal and not obliterated at all. And this can be seen in a video of a sliding sign, and you can see the entirety of the uterus and posterior uterus retrocervix sliding against the contents, particularly the bowel. So this is a non-obliterated pouch of Douglas. Here we have a video depicting a partial obliteration. So we have a right uterosacral ligament here, and you can see some peritoneum over here, the pouch. But on the other side, the bowel is adherent to the left uterosacral ligament and the left posterior uterine serosa. So because you cannot see the entirety of the peritoneum over the USL, this is partial obliteration. Here we have complete obliteration, as in our sample patient later. You cannot see any peritoneum at all. You cannot see any anatomy beneath these very dense adhesions. It is, if you were to simply look at this laparoscopically, you would have no idea what lies beneath it. So ultrasound is essential in these cases to be able to identify the areas of disease within the posterior compartment. And this would reflect in a negative sliding sign on ultrasound. You have no sliding of the posterior uterine serosa or posterior retrocervical serosa along the contents behind. And there's even a hypoechoic nodularity here behind the torus, likely representing deep endometriosis. To be able to assess the uterosacral ligament and the parametrium, the USL remains a very difficult area to identify. So in this side-by-side depiction, we have an ultrasound view of the uterosacral ligament as per this hyperechoic band here in the posterior compartment adjacent to the vagina, which is hypoechoic, and the thin hyperechoic band of peritoneum here. Imagine that when you do the ultrasound, the probe is looking in this view and you are slightly angled. In this case, if you're looking at the left uterosacral ligament, your hand is going to be anti or counterclockwise rotated to look at this left uterosacral. In this video here, we have the depiction of the uterosacral ligament. So we start at the video in the midline, and we see the vagina, the hypoechoic one, and the thinner peritoneum just here. And when we move our hand laterally, we can see this white line thickening, and this white line becomes the uterosacral ligament. In this depiction here, we have a deep endometriosis nodule that is partly in the uterosacral ligament but is extending laterally into the parametrium. And this is affecting the patient's ureter in this case. So here's a surgical depiction of this nodule. And you can only appreciate the tip of the iceberg, whereas in ultrasound, you can see the entire extent of the lesion, and you can even appreciate if the ureter is being extrinsically affected. Here we have a deep endometriosis nodule within the uterosacral ligament, and like the laparoscopic depiction of complete obliteration of the pouch of Douglas, you might not see that if you operated on this person, because they would also have an obliterated pouch depicted by this negative sliding sign. And this is the video depicting the hydroureter in the patient who had a uterosacral ligament deep endometriosis. You can see the very dilated ureter here that is extending from the area of the nodule. So there's the nodule here, and there's the initiation of the hydroureter just here. Very good. Next, we have our index case, a 45-year-old Gravida 5 Para 5 5005 who came in due to left lower quadrant pain and increased pain noted during menses. So on ultrasound, her cervix appears normal, and the uterus was noted to be anteverted midline with heterogeneous echo pattern and smooth contour. It measured 65 by 50 by 39 millimeters. The posterior wall was noted to be thicker than the anterior wall, respectively, with diffuse heterogeneous echo pattern. The endometrium had a thickness of 3.89 millimeters. It was isoechoic with indistinct endometrial myometrial junction. Both ovaries were located at the pouch of Douglas with median adhesions, the kissing ovaries. The right ovary appeared normal with few small follicles. This is the left ovary in relation to the uterus. And the left ovary measured 81 by 56 by 79. It was converted into a unilocular, thick-walled heterogeneous cyst with absence of intracystic vascularity. It was adherent to the left pelvic side wall with negative sliding sign. And at the superior portion of the left ovarian cyst is the dilated left fallopian tube that measures 30 by 15 by 18 with heterogeneous echoes seen within the cavity. The cul-de-sac had dense adhesions with no free fluid. So the anterior compartment was negative for any signs of endometriosis, but for the posterior compartment, there was a negative sliding sign noted, and endometriotic nodules were noted as well in the uterosacrals. So the right uterosacral ligament has an anechoic nodule here, measuring 7.8 by 6 by 5 millimeters with no vascularity, and the left uterosacral ligament was thickened. No hydroureter was noted. For the bowels, the sigmoid colon had an anechoic nodule measuring 15 by 16 by 7 millimeters, as well as a bowel nodule noted in the pouch of Douglas measuring 13 by 6 by 5 millimeters. So when we reported the idea, it is acceptable to simply state in a list such as this what was seen and measured. So for the anterior compartment, it was negative, and then adhesions were noted, negative by sliding technique, and then the nodule seen. And this was signed out with an impression of anteverted uterus, normal size with diffuse adenomyosis, menstrual endometrioma, bilaterality appears to be the left ovary. However, adhesions within the pouch of Douglas has limited probe manipulation to a certain laterality. Hydrosalpinx noted, normal size contralateral ovary, and deep infiltrating endometriosis, as seen in the IDEA results with bowel nodules, thickened uterosacral left, and endometriotic nodule in the right uterosacral ligament. Just a review of the IDEA report. Yun na po, Doctor.
Thank you.
Thank you, Priya, for that very comprehensive report. Are there any questions for the presentation of Priya? No questions, comments?
Well, if you do not have questions or comments, I would like to thank Doris. I'm so happy that you have already gained confidence in giving us the lecture on deep infiltrating endometriosis. And thank you, Kriya. It was a very good presentation. You have already learned how to locate your ureters. For other matters, do you have, I want to open the floor for any concerns about ultrasound, any problems that you encounter?
Doctora,
Yes,
Susan po.
Susan.
Yes, Doctora, regarding the disinfection, especially after in the morning when there was that in the evening or during madaling araw. Still, Dr. Sir Rod cannot assure us na nagagawa siya. I don't know why.
After, how often do you have this emergency ultrasound?
Not naman every day, pero minsan kasi in one night, more than one, ganyan. So, and there are patients coming from the ER, asymptomatic, still dadalhin doon. Sabi ko nga kay Sir Rod, alam naman nila based on the result of the ultrasound na binibigay sa kanila na merong stat. So at least dapat na-assure kasi 'di ba as manager dapat alam niya 'yon, doktora. Pero hindi niya ako
Hindi si
ma-assure.
Rod kasi yung ano nun eh, dapat yung duty nurse sa gabi.
Yun nga po. Pero what I'm asking from him, yung assurance to us. Kasi with the daily UV light disinfection, naglagay na siya kasi yun yung lagi kong kinukulit doktora sa kanya kung nagagawa. Yung the whole ultrasound section at the end of the operating hours. So naglagay na siya ng paper near
May
the
checklist.
spreader. Opo, tas may sign. Pero hindi rin nila napipirmahan everyday. Minsan after 3 days pagpasok ko, makikita ko 3 days walang signature. So sabi ko nga, paano kami ma-assure na nagagawa siya properly? Eh yun nga lang pag-sign, hindi magawa. Tapos when I asked the
Bakit
staff,
hindi? Pag hindi nag-sign, ibig sabihin hindi ginawa yon.
exactly, doktora, 'di ba? Tapos when I asked the staff, hindi rin nila masagot. So parang wala din silang, I don't know, doktora, hindi ko alam kung ako lang talaga yung concern, pero yung mga typist din natin, hindi nila chine-check eh. So they would call pa the office of Sir Rod to ask. Tapos later on, tsaka lang pipirmahan ni Myla, ay, ako yung nag-UV light yan, pipirmahan niya for 3 days. Parang, ha? Why can't you do that every day after, 'di ba?
Si Myla
Why
ba ang nag-UV light
it's either
every
si
after?
Myla or si Sir Rod daw po. Yun ang sinasabi nila. Sa gabi yun, doktora ha.
Nag-UV light? Nag-UV light si Rod? I
Sabi
don't think
niya,
so.
sabi niya
I
po,
don't
siya
think so.
pumipirma doon. May mga signature siya doon, doktora eh. Yun yung
Anyway,
sinasabi niya.
I will raise it up with him.
Opo. Pero yung concern namin, doktora, yung disinfection before the 7 o'clock start of the ultrasound operations. Kasi nga,
Wala ba silang checklist doon sa before the operation in the morning?
wala po. Yun yung hindi niya mabigay sa akin.
Okay.
Hindi niya
Sige,
mabigay.
we'll raise it up with him.
Okay.
Any
Thank you,
other
doktora.
concerns?
Doktora, I talked to Rod kanina. Nag-request na ako ng isolation gowns, yung to put on top of our hazmat para we can change it sa every patient. So aside from the hazmat that we're wearing, which protects us, the patients is also protected from us by wearing different isolation gown. Yung ginagamit natin sa DR, doktora, yung
Yung blue.
yes, magre-request na daw po siya.
Okay.
So it
Para
should
kada
be one,
pasyente palit.
Yes,
Opo.
kada patient, each patient palit para at least hindi naman din
Paliwanag
sila-
yung mabuti ha na each patient palit.
Opo,
Kasi
Doktora, hindi
para
kaya
yung
tayo
pasyente
maubusan?
protected. Kasi
Kasi, di ba,
kukonti na yun eh, di ba?
opo.
magre-request daw sila kasi we don't have enough sa DR. So baka DR naman yung maubusan. Pero magre-request, nakausap ko kanina si Sir Rod tsaka si mga pangalan ng isa. Umutan ko.
Si Miles.
Yes.
Hello, doktora.
Yeah.
Joanne po. Doktora, yung filter din po ng kasi malaki, yung dependent
Yung
din yung mga
filter, pinag-usapan namin kanina, yung filter pala, merong dyan sa machine, pakitingnan nyo nga, meron parang light na nagsasabi na yung filter ay kailangan ng palitan. So, pag naging orange yung light na yon, sabihin nyo kaagad kasi ibig sabihin nun, yung filter kailangan palitan.
Ni
Pero
doktora,
ang
dapat po every 6
pinalilinis,
months pinapalitan yon.
may yung machine natin may detector. Pag naging orange, papalitan. Yan ang sinabi ng ng taga-maintenance natin. So,
you
ang
mean,
katulad-
doktora,
nilinis
alam
yung
na yan
nasa
nila?
labas. Ha? Ang
Parang yung
nilinis
nasa
daw yung
delivery room,
cover
doktora,
nung
na
filter.
nag-blink ng orange. Yung nasa
Oo.
call room natin.
Yon, napalitan na yon. Bago na siya. Yung nasa call room.
So, kahit doktora, sobrang itim na yan hihintayin pa siyang mag-blink ng orange.
Ang pinalinis daw yung cover ng filter.
Oh, doktora,
Did you
pero sa
check
loob
now?
niya, itim pa rin.
Basta hintayin natin na maging orange. Kasi yun daw yung detector ng filter.
Okay.
Hindi nila i-order kung hindi orange ang ilaw. Yan ang sabi ng maintenance, ha? Okay. Anything
Alright.
else?
Doktora, reminder from PSOOG Secretary to pay daw your annual dues. I think yung iba, bayad na. So for the others.
So,
please
yan
pay.
yun dun sa dun
Sa
sa
website,
in-email
apo.
sa atin na website. Dun makikita kung magkano bill natin.
Yes, Doktora, nandun po. Tsaka kung paano magbayad, nandun din.
Nandun din.
Doktora, use GCash. Very user-friendly naman po yung portal.
Sorry dear, wala akong GCash. Okay. Okay. Anything else? So, ang kailangan nyo lang yung
Fellows
checklist,
Forum.
Okay.
Fellows Forum, Doktora, tomorrow po.
Oo. Kailangan umattend tayo doon. Magpakita tayo ng ating presence. Okay, that's it.
Apa, Doktora.
Thank you, everybody. Good night. Good afternoon.
Thank you.
Thank you. Nice to
Thank
see
you.
you. Bye-bye.
Thank you.